Hi, everyone. Welcome to today's Student-Led Journal Club seminar. My name is Anne-Marie Hayes, and I'm a research associate on the Joplin campus of KCU. Today, I'm going to be introducing our speaker, Daniel O'Brien. Today, he's going to be talking to us about modernizing the care of kidney transplant patients with biomarker cell-free DNA. Dan O'Brien, PhD, has a background in public health and is currently in the COB program at KCU. He is passionate about the discovery of new innovative biomarkers in the field of medicine, especially those patients who are diabetic and go on to end-stage renal disease and thus kidney transplant. So with that, the floor is yours.
Thank you, Anne-Marie. I'm super excited to be able to present to everybody, right? There's so much right now in regards to healthcare, and a little bit about me. Obviously, I've done some background research around biomarkers. So I come from a neurology background with multiple sclerosis, as well as even in the transplant space, looking at this biomarker cell-free DNA. So really what a biomarker is, as the cell dies, as it goes through apoptosis, it releases some of the cell fragments, and then it's also known kind of as a liquid biopsy biomarker, which is cell-free DNA. Really started in the prenatal space onto oncology, and now we're actually seeing it in transplant, right? So a lot of patients, like Anne-Marie had mentioned, if they go on to diabetes, end-stage renal disease, a lot of times the only option at that point is a kidney transplant. So instead of doing a very invasive biopsy, now there's biomarkers called cell-free DNA, which is able to pick up whether or not someone has a kidney rejection. So with our agenda, we're going to talk about the current state of kidney transplant medicine, limitations of diagnosing kidney transplants, cell-free DNA as a novel biomarker used in kidney transplant, and also the journal article JASON, right? Talking about the Journal of Nephrology that talks about some study objectives, study design, and conclusions that talks a lot about biomarkers and cell-free DNA. And also something that's really exciting, talking about the future of transplant medicine. Also, too, with healthcare technology, as we look at remote monitoring, telemedicine, even AI, looking at predictive analytics is pretty exciting, like we've seen post-COVID. So right now, the current state of kidney transplants. So transplant patients, as you know, they're on lifelong immunosuppressive therapy. As they go through the transplant process, they're often given a pretty tight regimen of therapeutic drugs in which they're on. So they're on these immunosuppressive agents, which is really, it's important for the patient to be on, but also, again, it can be very costly. And that leads to, again, just where healthcare is going in regards to the cost, the quality of care, as well as the access. We know just the cost burden that some of these kidney transplant patients are putting on is really, really crucial. So we're seeing a 500% increase in cost too for some of these patients going through renal transplant failure. So we know that graft loss also is a major issue for kidney transplant patients. The data shows, what we saw in the JASON article by Dr. Bloom out of the University of Maryland, shows that 20% of kidney transplants fail within 5 years. So really the key to that is, okay, how do we monitor these patients? And this is where the biomarker cell-free DNA comes into place. And really what a biomarker is, it's a biological tool, right? To be able to catch, things early, not only in transplant, but other diseases. If you're able to catch a biomarker early, that is really pivotal as well. So current limitations in diagnosing kidney transplant rejection. So really the gold standard, kind of the current standard of care is utilizing serum creatinine. But what Dr. Bloom showed and what the JASON article showed is really there's other options as well. Serum creatinine, it's almost like flipping a coin to say, okay, is a patient going to have a rejection or not? So that's an option. It's very non-specific, not sensitive. And there's a risk of a late signal with serum creatinine. So that's an option. Also an option is a kidney biopsy, right? That can be, as you can see from the picture, very invasive going through that process. And it can be very harmful with potential for complications as well as interpretation challenges. So that can be a huge, huge issue. So that's where the excitement of the research is going with cell-free DNA as a biomarker, as a non-invasive biomarker. You don't have to worry about a high cost or a very invasive procedure like a kidney biopsy. So the presence of cell-free DNA as a biomarker, a little bit of history, right, for the history buffs out there. This was first described by Mantelamiadis in 1948 So there was really 3 years before the discovery of the double helix. So cell-free DNA has been around for a very long time, which is interesting. And the data continues to show more journal articles are coming out with utilizing cell-free DNA as a biomarker. And what's exciting is not only in kidney transplant, but maybe you can use this in heart transplant, you can use this in liver transplant, pancreas, dual organs. So certainly a lot of opportunities for cell-free DNA. Circulating cell-free DNA is found in the serum. It's found in the urine, saliva, as well as the CSF. What's been shown in the research too is a potential for a urinary biomarker, right? Again, another non-invasive option for these transplant patients. I mean, imagine going in, you're getting a new kidney, you go through the procedure, and then you have to do follow-ups with all these kidney biopsies. Why not have a really simple solution with a liquid biopsy with cell-free DNA as this biological biomarker? So cell-free DNA can be cleared by the blood, or be cleared from the blood by the liver and kidney with a half-life of about 30 minutes. So again, this donor-derived cell-free DNA can provide a non-invasive and accurate, really accurate description of rejection as well as surveillance, right? You can use this maybe as for cause, as a patient comes in on the spot to determine if they have rejection, or you can utilize surveillance down the road as well. So certainly a lot of opportunity with biomarkers. Again, this is really heavy in the research, not only in transplant, but we're really seeing this almost in every industry, including others in neurology, right? As we look at Alzheimer's disease, as we look at ALS, and others, I think in neurology and also other disease states too, which is really, really important. I think that's going to really improve the outcomes for patients. Here's the JASON article talking about cell-free DNA, the kidney rejection and kidney allograft by Dr. Bloom out of the University of Maryland. So what he talked about in the study was comparing the performance of cell-free DNA to the performance of serum creatinine. Again, we know that the gold standard right now is serum creatinine, but to challenge that a bit, we know that serum creatinine, according to the data, according to the JASON article, it's like flipping a coin. But if you had cell-free DNA as a biomarker, again, that can be able to detect rejection in a much more accurate manner. Also, the article talks about determining the ability of cell-free DNA to discriminate rejection from no rejection, and also the ability of cell-free DNA to discriminate antibody-mediated rejection, which is ABMR, from no ABMR. These are the patients that really gets to almost a train wreck status where it's, you don't want your patients at ABMR, right? So this article talks about looking at cell-free DNA and how that can discriminate between ABMR, no ABMR, rejection versus no rejection. And also, again, this idea that cell-free DNA can improve the performance over serum creatinine. So this was a prospective observational study. Renal transplants were enrolled 1 to 3 months of their kidney transplantation and or at the time of clinical indicated renal biopsies from 14 clinical sites around the country. After transplant, blood was scheduled at the time of scheduled surveillance at months 1, 2, 3, 4, 6, 9, and 12, and up to a 2-year follow-up within 8 weeks of the kidney allograft biopsy. And also cell-free DNA was used using a targeted next-generation sequence assay that employs about 266 SNPs. So going back to your biochemical days, or biochemistry, single nucleotide polymorphisms as well, in order to quantify cell-free DNA in transplant recipients without the need for separating genotyping of the recipient or the donor. So again, here is the article, the JASON article that Dr. Bloom talks about. So what we kind of see in the figure, looking at the left-hand side is your cell-free DNA. And again, looking at the right-hand side is your serum creatinine. So we know, again, according to the article, that cell-free DNA accurately discriminates rejection from no rejection and outperforms serum creatinine. So just to kind of orient you to the graph, on the upper left, right, we're looking at cell-free DNA being able to discriminate active rejection from no rejection, whereas on the right-hand side, it's just a toss, right? It's a coin flip. You don't know with serum creatinine if you're going to get rejection or not, and that's why it's so important to have this non-invasive biomarker cell-free DNA. In the middle column right there, it's an AUC curve. So we have 0.74 on the left-hand side with cell-free DNA and 0.54 on the right-hand side. We know with AUC, which stands for area under the curve, how important it is for it to get to 1. So the closer it is to 1, the more accurate that is. So really pivotal. Again, this is showing that cell-free DNA with an AUC of 0.74 is a pretty accurate test compared to serum creatinine. On the bottom graphs, talk about sensitivity and specificity. What's really good, according to the article, is the fact that cell-free DNA came out with about a 95, 96% negative predictive value, which means being able to rule out rejection. So you can say with cell-free DNA, 95% of the time, you can rule out rejection. No, nothing else offers that. You can't use serum creatinine to completely rule out a rejection. So certainly an interesting point from the Jason article and Dr. Bloom as well. So in summary, again, this cost of missed rejection and late allograft loss to individual patients in society as a whole is enormous, right? We know that cost is big, access, quality of care, but the burden of cost that these transplant, particularly kidney transplant patients are going through is huge. So why not, again, don't go through the costly, biopsies. Now we have an alternative in the research with cell-free DNA. So current non-invasive tests for active rejection in kidney transplants are suboptimal. Cell-free DNA levels increase in the presence of allograft injury. So again, if you have an allograft injury, you're going to see a rise in cell-free DNA, which makes the clinician think we can actually act on this a little bit quicker. Cell-free DNA levels may reflect rejection status. And again, what's been shown is cell-free DNA outperforms serum creatinine in diagnosing active rejection and also provides a way to improve the long-term monitoring of kidney transplant recipients. So as these transplant patients are on immunosuppressive agents, you can actually monitor through cell-free DNA in order to optimize treatment, which is really important for the patient. So again, in conclusion, cell-free DNA is a great surveillance test to detect graft injury and determine rejection. Cell-free DNA is more accurate than serum creatinine in the diagnosis of rejection. Cell-free DNA levels decrease following rejection treatment, which is really important because then the clinician, the nephrologist or the surgeon, again, can really kind of adjust the dose. And cell-free DNA may be used as a predictive tool for decreased kidney function. So EGFR really monitors how well the kidney is doing overall. And you can look at cell-free DNA to see, is there patterns with EGFR and how is the patient's kidney overall responding? And this is what's exciting too. As we look to the future of medicine, right? There's so much right now in transplant, not only in transplant, but even with some of these biotech companies looking at cell therapy, looking at the transplantation of human cells to replace or repair damaged tissues or cells. Also looking at remote patient monitoring, right? We saw kind of post-COVID how important remote patient monitoring really is, especially for these diabetic patients, even for these transplant patients. Transplant patients are looking at, follow-up of, let's just say 6 to 10 follow-ups after their transplant. What if we had a really good idea with remote patient monitoring to be able to, again, improve outcomes? And also too, predictive analytics with AI. What if you're able to predict graft survival, let's just say 3, 5, 7 years down the road through this predictive analytics, through AI? We're seeing AI all over healthcare, which is really exciting. And of course, lastly, telemedicine. Obviously, there's a lot of excitement post-COVID around. Now this improves the access to patients, particularly in rural areas where patients really need to see a physician. This is where telemedicine can really, really make an impact. So this is where I think the future of kidney transplant medicine is headed. Also, other disease states as well. So I think it's time for innovation. So thank you so much, and open to any questions or comments.
Awesome. Thank you so much. That was a great presentation. It's funny you bring up AI because actually 2 weeks ago, our speaker talked about AI related to gastroenterology. So quick plug for that. If you're interested in AI and medicine kind of a thing, I recommend going back and checking out that one. But I had a couple of questions, but also I don't want to jump in front of anybody. So if there's any questions in the audience, feel free to raise your hand in Zoom or type them in the chat if you can't unmute.
Sounds good. Thank you.
One of my questions is, you talked about this being also kind of the cell-free DNA being involved in, I think, neurology and something else. I guess I was a little curious about how much you looked into more in that area, like where else is this being used and how far has that research progressed?
Yes, well, my original great question. Thank you. My original kind of idea was when I did research with MS, looking at biomarkers, so in the neurology space of MS. And really, I think that cell-free DNA, I mean, could be incorporated, I think, in neurology, but I think most important, utilizing biomarkers in the neurology space. So for example, take Alzheimer's disease, maybe NFL, neurofilament ligaments, as well as looking at GFAP as well, could be really important, or even looking at complement factors 3 and 4 as biomarkers. And even I think in not only Alzheimer's, but I think ALS as well, as they look at NFL or either GFAP as potential biomarkers to essentially catch it early. So again, that can improve maybe the outcomes of the patients and even monitor as well through their progression. So I think the whole idea is catching it early. I mean, take ALS, for example, you're talking about living 2 to 3, maybe 5 years max. So hopefully I think there's, really good research with ALS being kind of a rare neurological disease. Alzheimer's has a much bigger market. Obviously, more people have that. But I think if we can catch mild cognitive impairment, MCI, a little bit earlier in Alzheimer's, especially now, some research, they're kind of correlating some diabetic issues with that. There's some trials using diabetic medications. Could be really interesting as we improve outcomes for Alzheimer's patients. But neuro health right now is absolutely huge. To your point, a lot's going on there.
Awesome. And then one other question I had is less about the topic and more about you, I guess, but why are you passionate about kidney transplants in particular in this area?
No, great question. So what kind of generated my interest in healthcare was really my aunt went through a kidney transplant. She was in end stage renal disease or diabetic, and then ESRD, end stage renal disease, and then on to a kidney transplant. So that I saw that kind of at a young age, and that kind of really motivated me to get in healthcare and to say, how can we really have maybe some non-invasive options? People are going in after a kidney transplant with all these biopsies. Is there a liquid biopsy? Is there a potential to have a non-invasive option for these patients, like my aunt? And that really drove me, I think, to my passion eventually to being here and to drive the science on the healthcare standpoint.
Awesome. Yeah, no, I definitely agree. The less invasive you can be, especially after a major surgery like a kidney transplant, I'm sure the better and more comfortable your patients will feel. So definitely.
Exactly.
Anybody else in the audience have any questions, comments? Dr. Wolf?
Actually, this was rather interesting to me because I don't know anything about the use of cell-free DNA like this, and I apologize for not reading the paper beforehand. But as I was sitting there and looking at your presentation, a number of things came up. So my question related to the fact that I didn't understand how these were actually being used. So are you measuring the levels of circulating free DNA? So I saw that the average base pair size was like 167 with a quick Dr. Google search. But what with the base pair size, what use those SNPs were? I mean, a SNP is genetically based. So why is a SNP, why or how is a SNP important? So those were things that from a first blush, I didn't necessarily get. And why would that be better than just acute markers of inflammation that for which there's already many?
Yes, no, great question. I mean, it is kind of, I think cell-free DNA could be a marker of inflammation. I think when you look at the NPV of cell-free DNA, in some instances, tests being utilized now with a really high negative predictive value strongly suggest a lot that I think it could be very, very useful for these kidney transplant patients. And it's a little bit more specific. I think to your point, though, I think you make a really good point. I mean, I could say this could be an inflammatory, I guess, biomarker per se, that's a little bit more specific than, say, what CRP, something that's maybe not as specific. But I think there is a lot of potential with utilizing this with just a little bit more specificity as a biomarker, just compared to doing a little bit more granular compared to this just overall inflammation.
Well, I mean,
Good point,
how is it selective? I mean, I saw that there was the wider range, but you could sit there and argue that many people did not have high circulating levels based on the scattergram that you showed there. And, so if somebody has hepatitis or something else, would that not be a false positive? with this.
At least I think it kind of alerts the clinician to do further testing, just in case, again, to be able to rule out other inflammation. I think to your point, it's certainly a really challenging point that there could be other inflammatory things going on, but I think it does at least provide an additional tool to the clinician to realize, okay, we have something here that could potentially help the patient instead of just continuing to go on with a biopsy. This would be used maybe as another surveillance tool for the clinician.
And then the final question that I had, again, it's been, I am a kidney guy, but it's been many years since I looked at all of this stuff. But my recollection is that the truly unmet need is for preventing chronic rejection. And chronic rejection is not an inflammatory process. The kidney just slowly but surely turns into a scarred mass that's not functioning properly. So is that something that's acted here?
Yes, I think here, I mean, you're looking at a surveillance tool that can be used over a period of probably 2 to 3 years as you get different serial points with cell-free DNA. So if you set up maybe a testing surveillance schedule, let's say over 2 or 3 years, say if, once a quarter over the next, or a couple times a quarter for the upcoming years, I think that you could use this and to look potentially catch chronic rejection as well, because your surveillance, not only acutely, but also chronically too, could be potentially a use for it.
Well, I mean, I guess I was just sitting here thinking as after I asked the question you were talking now, I mean, part of the deal of what you're detecting is cell death. And it seems to me that some of what we've got going on there is an epithelial to mesenchymal transition, similar to what might happen in cancer or something else, where the cells just change their phenotype and they're no longer an epithelial cell. They're a fibroblast-like cell. And so they wouldn't be dying, and they then wouldn't be contributing their DNA to that pool.
No, it's an interesting point. I mean, because as we look at cell-free DNA, essentially apoptosis, as the cell dies, it releases those cell fragments. And what's interesting with cell-free DNA as a biomarker, it really started in the prenatal space, onto oncology and then on to transplant. So I think you mentioning, with cancer, it certainly makes sense, as transplant has learned a lot from probably oncology.
Thank you everyone for being here on your Friday afternoon, and thank you so much again, Daniel.
Yes, absolutely. Thank you for the questions, and thanks for the invite to be here. Really enjoyed it.